things. That's just one of those things. He also states that he never saw a pre-post x-ray the entire time he was in school. See, I heard him saying these things. I was listening to one of his videos on seminar videos, and I was just thinking to myself, man, that really sucks. This guy really wanted answers, and all he was getting was just a runaround. All these questions, no answers, right? So I was in lab the other day, and a few of you guys were in there with me, and my professor was talking about leg length inequalities and how reliable inter and intra-reliability of leg length checks. And I was like, okay, and then he said there were a lot of studies done, and then he went on to say how those leg length inequalities correlated with certain listings. And so I raised my hand and I said, are there studies done to show that those leg length inequality findings correlate with those certain listings, like an x-ray, to show that those listings are what you're finding? And he said no. And so I asked him, I was like, so how do you know you're addressing the correct subluxation then? And his answer was, well, Randy, he's like, basically, in chiropractic, there's not a lot of research that's been done. So unfortunately, what chiropractors have to do is they have to just practice until they find out what gets results. And so then I said, well, what do you mean by results? Like symptom changes? He's like, yeah, symptom changes, stuff like that. So as I stared dumbfounded as he rambles on about how chiropractors just essentially use trial and error, I thought to myself three things. The first thing I thought to myself was, well, all we do here at Life University is rag on medical doctors and other pharmaceuticals, and because they're just trying to address the symptoms, right? And we're supposed to be addressing the cause. Yet it seems to me that every time I talk to one of the professors here, they're talking about results, they're talking about symptom changes. And that kind of pisses me off a little bit, because it kind of seems like we're incongruent, right? We're not backing up what we're saying. And that's why a lot of other professions think we're a joke. And the second thing I thought was, is this guy just giving me the runaround? The same runaround that Dr. Pierce got back in the 1950s, not giving me a clear answer about any of my questions? And then the third thing I thought was, I've been at Life University for 2 years, and I've never been shown a pre-post x-ray in any of my classes. Is this a coincidence, or is it just one of those things? Because for me, as a chiropractor, I just want to be able to tell my patients three things with certainty. I want to be able to tell them, yes, I can find your problem, yes, I can do something about your problem, and yes, I can show you proof that I've done something about your problem. So thankfully, I found the Pierce Results System, because without it, I'd be lost searching for one of those things. And a huge thank you to this man, Dr. Vern Pierce Sr. He's a true pioneer in the chiropractic profession, and I think he said it best. He said if you do it and can't prove that you did it, then you probably didn't do it at all. So if you want to be able to prove that you did it and you're interested in learning about true, specific chiropractic, then you've come to the right place. And before we go into exactly what the Pierce Results System is all about, I have a couple of individuals who want to share their story with you and the impact that the Pierce Results System has had on them. So the first person we have is Lauren Smedley. She's one of the most compassionate, caring people I know. But don't talk about New Jersey or she'll rip your head off. Give her a round of applause.
Just a little defensive when people call it the dirty Jersey and stuff like that. So, as you can see, this is my x-rays. The one on the left is my x-ray that I came in at first quarter. Now, it's interesting to me because I worked at a chiropractor's office for 2 years. And he is one of the most amazing people that I've ever interacted with. He got me into chiropractic. He spoke philosophy, lived and breathed it, but at the same time he spoke about all these things that we hear in philosophy classes or outside at whether you go to Life Vision, DE or whatever. And you talk about like primary subluxation, let the body heal on its own. We don't chase symptoms. We find as Randy was talking about, we find the cause. Yet in so many ways, we are incongruent with that. So I didn't really understand it at first, but when I saw this x-ray, I was like, okay, that's really not the normal curve that they talk about, the banana curve or whatever it is. And it kind of blew my mind, especially learning from the Pierce that I have basically a flat atlas angle and then a completely straight neck. And yet I was being adjusted at least once a week by, in my opinion, one of the best chiropractors in the entire world. Not to take anything necessarily away from him because he's an amazing person, but look at my x-rays after, this was just recently taken this past January, and as you can see, my curve has completely started to come back, and my atlas angle is almost to normal. So I think it's pretty awesome that we can show pre and post x-rays, as we'll see in a moment someone else who's a student here who could make pre and post x-rays. But I know in a lot of also in educational purposes in chiropractic, we talk about, we show this as like, oh look at, this is your spine degenerating, blah 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 blah, like this is their problem area, this is how we're going to help you. But not one health talk that I've been to or reported findings have they ever shown a post x-ray, unless it's been a pure stop. And I mean, if you guys know other one, tell me about it, and I'd love to hear about it. But I think that's one of the awesome things, is that we can show that, and we can show it in, it doesn't necessarily take, oh, your entire life. Like this was just after 2 years, and this was just with chiropractic Pierce Care, and it was with a student, or not. It's possible, and you can do it. So I think I'm healing pretty well, aren't I? Yeah.
Next up is Sam. So Sam's going to share his story with you. Sam and I have been coming to club for 8 quarters now. Sam's never missed a day of club. He's never missed a seminar. And his dedication and his resiliency have paid off. And he's here to share his story with you. So thanks, Sam.
So this is a patient that came into Dr. G's office, Dr. James Galgano, if any of you guys know him. I was shadowing him over Christmas break. This patient came in, to give you a little bit of background on this patient. She's a 48-year-old female. She's had headaches 4 to 6 times a week for the past 20 years. She's had mid-back pain for the past 20 years every day, constantly. She's had low back pain for the past 25 years every day, constantly. She has foot pain. She has fatigue. She also has recently been having a lot of cardiovascular problems. She's had just probably past 2 months ago, she had a heart attack-like response. She had to go to the ER and everything like that. They couldn't figure out what was going on. So then this patient came into Dr. Galgano's office, got the full workup, the x-rays, the fluoro, the Titron scan, which Randy's going to get into that in a little bit. She got the full workup, found her subluxation, adjusted it, got a great scan change, and her subluxation was C4, and then we also adjusted the pelvis. In addition, you can see the pre-post pelvis change. You got a structure change. A lot of you guys that have been to club will get a better idea of this, and if not, if this is your first time here, you'll get it when you come to club. But the red line is where her sacrum is, and the yellow line is where it's supposed to be. And you can see down at the bottom, this obturator is larger than this one. So what that's saying essentially is that the sacrum came posterior on the left, and it made that ilium. If you can look at the ilium widths, they're a different length as well. So that's pre-one adjustment, and this is post the left IN adjustment. You can see the sacrum came back perfectly over the center line. Her lumbars are off center a little bit, but that's because she has a malformation here, and that's her normal. So we don't want to try to force that back over, else that would just cause more problems to begin with. You can see the obturators balanced out, and then the ilium widths balanced out as well. So a little more background about this information, and kind of what it really drives me and pisses me off is the fact that this patient has been going to a chiropractor for 8 years, once a week, and had no response to any of her symptoms, one. So he did a great job of educating his patient, because she came once a week for 8 years without ever getting any kind of results, whether symptomatic or structures, because he took an x-ray on her first visit but never post-x-ray to see if he made any change. So this person has been going to a chiropractor for 8 years, full spine diversified chiropractor, very successful. It was actually the guy who got me into chiropractic. And, she had no, positive experience, symptomatically wise or functionally or anything. And she's been going there for 8 years. And that frustrates me, because we have the most amazing philosophy that your body's a self-healing organism that, can adapt to anything, essentially. And subluxations limit your body's ability to do that. So you should go to the chiropractor to help you with that. Yet she was going to the chiropractor once a week, and she was diligent with it, and went every week, and still no response whatsoever. And the thing that drives me even further is that this patient is my mom. And it pisses me off the fact that she's able to go for that long to a chiropractor getting no results. And I told Randy I wasn't going to cry, but it's my mom. So as you can see, when we got the thermography change, we didn't have them up here, but she has a structural change. We removed the subluxation, now she has a structural change in her pelvis. She has a functional change in her scans, meaning her body's adapting to the environment better than it ever has. Her pain's pretty much entirely gone. No headaches. She hasn't had headaches in 4 weeks. And granted, she was having 4 to 6 a week for 20 years. She hasn't had a wet headache in 4 weeks. She texted me yesterday because we had 37 inches of snow back home in Pennsylvania. And she was shoveling snow for 7 hours and pushing 12 cars out of the snow. And no back pain, no headaches, nothing. Like, her foot pain's getting better. Never touched her foot. Her fatigue's better. It didn't do anything metabolically to improve her fatigue. Like, that's just getting better. She hasn't had any heart attack, or not heart attacks because she didn't have one, but any heart trouble, heart pain, or anything like that in 4 weeks. And she's doing great. She texts me every day. She's like, no headaches again. I worked 12-hour shift at the hospital. No headaches, nothing. Everything's great. I'm like, it's crazy. And the thing that makes it even more special, because it is my mom, is the fact that I gave her the adjustments. And as a 10th quarter student, that isn't to say that I'm a good adjuster, because truly the chiropractor she was gone to, he could move any bone. You know, he can make any bone audible, he can move it anywhere he wanted to, but it didn't make a damn difference because it wasn't on the subluxation. And we did the analysis, got it on the subluxation, and the rest speaks for itself. So.
Is it dusty in here?
Absolutely.
The whole back corner of girls back there.
I told myself I wasn't going to get emotional.
Made it even better, man. Good stuff. I don't even think I can talk after that. We should go home. All right. So they got those results, and I'm going to show you how they got those results. All right, Luke, you just want to see that?
Yeah, I came just to watch that.
You can't get out that door, it's barricaded.
See you, buddy. All right, so what is the Pierce Results System? So the Pierce Results System is a system of analysis to analyze the spine in chiropractic, right? So you can utilize this system of analysis with any adjusting technique you want. So it's not an adjusting technique. So if you wanted to use the Pierce Results System of analysis with constant adjusting, you could do that. Okay, is that clear?
Yeah.
Yes.
Okay. All right. So Dr. Pierce created the system in 1975, and he continuously developed the system until the day he passed away on December 20th, 1993. All right. So Dr. Pierce believed that as technology advances, so should the profession. And our vision here at the Pierce Results System is to take a scientific approach to chiropractic. We utilize the most advanced tools available to our profession, and we use these tools in order to get a specific objective analysis of the spine. We're analyzing the spine for what? Subluxations. So we believe that 95% of your work is the analysis. Once you put in a thorough analysis, the rest of your job's almost done. Because once you have the analysis, you know where you're going to adjust, and you can adjust that bone with the greatest amount of precision. So what does our analysis consist of? So our analysis consists of thermography, static x-rays, and video fluoroscopy. We're going to run through that here today. But before you do any type of analysis, what do you want to get on your patient? What do they say is the most important thing to get on your patient? Case history, right? So we would usually get a pretty in-depth case history, but for the sake of time, I'm going to do just a brief case history on my patient here today, who is Dr. Andrews, if you guys don't know him. So come on up, Dr. Andrews. Bring that chair and you sit right here for me. All right. Perfect. All right, Dr. Andrews. So what brings you into the office today?
You.
Besides that.
I have a stiff neck, lower neck. I have some slight tingling in a couple of my fingers when I wake up in the morning.
Can you guys read that?
Mm-hmm.
Which fingers?
Usually little finger and ring finger,
Okay. So
both sides.
bilateral, tingling, fingers 4 and 5.
And sometimes I pull my low back on like my, what would be the QL, my quadratus. Sometimes I pull that, lifting.
A patient would never say that.
So yeah, so when I'm going over this analysis with Dr. Andrews, I know
Don't cry.
So since I know Dr. Andrews is the doctor of chiropractic, you can talk to him on a higher level, right? You can talk to him more anatomy because he's going to know what you're talking about. I hope. So you strain your QL often, or sometimes when you're working out?
Yeah.
All right. And Dr. Andrews, have you had any recent trauma that you would think could elicit any of these symptoms? Recent accidents?
2012 car accident.
Car accident 2012. Okay. So I'm not going to go over OPQRSC, right? That's this case history for today. So we got his symptoms, and that's what we're going to do. So, you guys want me to? No. All right. So the first step in our analysis is thermography. In my opinion, thermography is the most underutilized tool that we have available to us as chiropractors. Because as chiropractors, we pride ourselves in being masters of the nervous system, right? And the most advanced objective tool that we have at our disposal to measure the nervous system, well, at least in our price range, is thermography. So here in the Pierce Results System, we use the Titron. So the Titron is a dual-probed digital infrared thermography instrument, and what it does is it measures paraspinal asymmetries in the spine. So it's just measuring the temperature of your spine. All right, and I'm going to show you what those scans look like here a little bit later. I already scanned Dr. Andrews a couple times, but it's on a different software, so we're going to have to transfer that over, but we'll get to that. So what do we use thermography for? First thing we use thermography for is it tells us when to adjust. Not where to adjust, but when to adjust. It also tells us if our adjustments were effective. So we use pattern work, which we're going to get into here in a minute. And what we use pattern work for is to establish their neurological baseline. And then once we have that, we adjust them, post-scan them, because we want to break that pattern. And I'll go more in depth about that here shortly. Second thing it does is it holds us accountable. For a lot of people, I don't think they like to get held accountable for their work. For me, what's up, Baxter? How you doing, buddy? So for me, I use thermography at my house, and I take care of patients. Like, I'm not scared to say it. But there have been times when I've adjusted 5 or 6 patients in a row, and I haven't gotten a scan change. And it can be a humbling experience, right? But it doesn't make me want to quit using the Titron. It makes me want to get better at adjusting. The next thing it does is it prevents us from over-adjusting. Dr. William Amelou, who does most of the research on thermography, he's also a chiropractor and a board-certified thermologist, said that if you're adjusting a patient who's not in pattern, you can actually cause them neurological trauma and make their health problems worse than they were before. So is it really possible to be over-adjusted? I don't know. There's not really scientific proof on it. But in my own experience, I've seen a lot of stories like this. This is Lindsay. You just met her a little while ago. As you can see, Lindsay has absolutely no lordotic curve left in her neck, right? Your neck should be shaped like that, right? You should have
Just for like a little bit so you can see it.
should have a curve. All right. So if we're looking at her, she lost her entire curve. This is a straight neck. It's almost going kyphotic. Also, if you look at it closely, if you're looking at the anterior portion of the vertebral body right here and the posterior portion, you can see stair stepping right there. What that stair stepping indicates is ligament damage. And we all know ligament damage is irreversible, right? Ligaments are avascular, so that's not going to heal. And Lindsay has never been in one major accident her entire life. However, she was going to an unspecific chiropractor her whole life. Lindsay, can we turn the lights back on, please? Lindsay, can you tell us a little bit about like the analysis that your chiropractor did and how he adjusted you?
Yeah, and just so everyone knows, that picture is now worse. I would love if my neck looked like that right now, but it's definitely worse than that. I started seeing a chiropractor, I think, when I was 2, and it was always pain-based, so wherever it hurt on my neck, that's where I was adjusted. When I was 22, I started working for a chiropractor as a CA. That was the first time that I ever got x-rays taken, thinking that I was going to look beautiful. I didn't. So he adjusted me 3 times a week for over a year and a half, and I never saw any change. I think he was doing the best that he could. I think he was giving me the best care that he knew how, and what I have taken away from that experience is that there's something better. I think I'm very lucky that I found what is better. If it's not getting better 3 times a week, that's a lot of force going into someone's spine. So I would challenge you to check yourself. I think if he could check and know earlier that what he was doing wasn't necessarily helping, I don't know if he would have progressed down the same path.
Thanks for sharing your story with us, Lindsay. We appreciate it. So what Dr. Pierce found was that the worst subluxations that he saw came from individuals who were getting unspecific manipulations. Some of those chiropractors were using the most specific moves that you can think of. And he says it best. So the sloppiest adjustment in all of the world is by far the greatest adjustment. It's on the right vertebra in the right way at the right time. And the most specific adjustment in all of the world is absolutely the most harmful subluxating force. It's on the wrong vertebra in the wrong way at the wrong time. So this ties back into exactly what Sam was just talking about with his mom. That chiropractor had 20 years of experience adjusting people, right? He might have been able to move a bone better than anyone else. The fact is he wasn't on the right bone. Sam was on the right bone. Sam has what, a year of experience adjusting?
Yeah.
Granted, he's a really good adjuster. But he's not as good as someone with 20 years of experience, right? He was on the right bone, and that's what mattered. See, stories like this, that Dr. Pierce said, stories what Sam said, Lindsay's story, they're always in the back of my head. So currently, I'm in student clinic, and I catch a lot of crap for kind of sticking to my principles in student clinic, right? So I get nicknames like One Bone Randall because I'll only adjust one segment at a time. I also am not going to adjust someone's cervical neck without having their listings off of video fluoroscopy or X-ray. That's just what I believe in. So I'm not going to do it. So we had another doctor, me and my reciprocal, Tyler, come up to us last week, and I've never seen him before. I think he's from outpatient, but he actually, the first thing he said was, "You guys are pussies," and I was like, "What? Did this guy really just say that?" And I didn't even get mad. I was just really surprised, and I said, "Why?" I'm like, "What do you mean?" And he said, "You're only adjusting a thoracic?" I'm like, "Yeah." And he's like, "You should be adjusting a cervical, a thoracic, a lumbar, a pelvis, a sacrum." He's like, "If you don't adjust all these things, you're not going to get paid in practice." And I was like blown away, and I was like, "Tyler, you just need to go talk to this guy before I start saying shit to him." And to me, like, I do see people getting adjusted in student clinic 4 or 5 segments at a time. And they're seeing these patients every week. Do you guys think that a 20-something-year-old healthy individual is going to have 5 or 6 subluxations per week? What are they doing, getting run over by a car every weekend, coming back with 5 subluxations? Because we as chiropractors say we only adjust the subluxation, right? So are we just going in there adjusting 7 bones so that we find the one that has a subluxation? If you went to a dentist and they didn't x-ray you and started drilling every one of your teeth until they tried to find the cavity, would you like that? No, right? Isn't that the same thing? I don't know. That's the way I look at it. You like it? See, I'll get picked on, I'll get called names in student clinic by these clinicians, but I'd rather take that shit than go against my beliefs and go against my principles. Because I don't want to be responsible for someone's neck looking like this. Sorry, Linz. I just don't. So let's move on. All right. So this is what we use thermography for. We use it to establish a pattern. So are we all familiar with pattern work? What pattern work is what we want to do is we want to scan the patient 3 times, at least 10 minutes apart, within a 24-hour period. And what we're looking for is we're looking for symmetry in scans. So we're looking at the left probe compared to the left probe, the right probe compared to the right probe. We're looking for symmetry in these lines. We want that, or we don't want them to be, but they're going to be identical, right? And that's their pattern of interference. That means that their nervous system is not able to adapt to their environment. So we all know what homeostasis is, right? We should be constantly adapting to our environment. So if our nervous system's not always changing, there's something blocking that, a subluxation. So our goal is to remove that subluxation and get a scan changed. So once we get their pattern, we adjust them and we post-scan them. And all we're looking for is any type of change. There's not a good or a bad change. There's a change, and every change is good. And we're not going to adjust them again until they get into another pattern. Does that make sense? All right. Second step. Like I said, we already did the thermography on Dr. Andrews, so I'm going to show you guys that later. But the second step is the X-ray analysis. So what do you use the X-ray analysis for? It doesn't replace, video fluoroscopy does not replace our static films. We still need the static films to look for pathologies and abnormalities. We also use it to look at the overall structure to kind of give us a clue as to where to look on video fluoroscopy. But the most important thing it does is allows us to educate our patients. So these are all lines that we use and through our analysis to educate our patients. Because most of them aren't going to be able to read a video fluoroscopy, right? So the structure, you're going to have to show them these structural changes, and it also helps us as doctors when we take a post X-ray know if we're actually helping the patient or not, or fixing them structurally. All right. So what I'm going to do is, Dr. Andrews is my patient, right? So before you show him his X-rays, you're going to want to show them what normal looks like, so they have something to compare it to, right? So I'm going to go over it with him. All right, Dr. Andrews. Can we turn down one of those lights, maybe?
I don't know.
Or is it just, it's all or nothing? Let's do, that's good? Okay. All right, so what we're looking at here, Dr. Andrews, is what a normal spine should look like. So we have this line, it's called the patient education line. We want all of the anterior vertebral bodies to be touching this line, and that's what we call a perfect curve. The next line we have is the gravitational weight line. What we should see here is 1, 2, 3, 4, and between C4 and C5 should be approximating that line as close as possible. Any bit of posteriority to that line is anterior head carriage, and so that's measuring your anterior head carriage, okay? Then the last line we draw is the atlas angle. So normally your atlas should be at a superior tilt at 18 to 24 degrees, okay? So that's what normal looks like. I guess let me point this out too. We have, if we're looking at the discs, these are the intervertebral discs between the bones here. We want them to be symmetrical, healthy looking, and those all look about the same size, right?
Yeah, they look good.
All right.
I look great.
Here's you. All right. So what we're looking at here, this is the same patient education line, and as you can see, none of your vertebrae are touching that line. So what that means is that you have a loss of your lordotic curve, or the normal curve that you should be having in your neck. And then if we're comparing it to the gravitational weight line, we have 1, 2, 3, 4. We're looking at this area right here. The space between that looks at least 2 inches from it, right? So for every inch posterior to that line, it adds 10 pounds of weight that your neck and your body have to carry around on your head. So the normal head, yours might weigh a little bit more, is 10 pounds. But we're going to add 20 pounds to that you're having to carry around all day. If you think about it, if you're holding a bowling ball here, it's a lot easier to hold here than it is out here, right?
Yes.
So what your head's doing is your head's translating out like that. So at the end of the day, why you're feeling a stiff lower neck is because of that anterior head carriage. So our goal is going to be to get it as close to this line as possible. All right? Yep. And then the next thing we're going to look at is the atlas angle. So if you guys can't read that, it says 14.8. And I said the normal is 18 to 24. So what's happening there is your atlas is beginning to lose the superior tilt. So it's almost parallel with the ground here. So we're just starting to lose that superior tilt. When we lose that superior tilt, it begins to put pressure on the brainstem. So your brainstem relays messages from your brain to the rest of your body. It also controls everyday physiological functions such as breathing, heart rate, and blood pressure. So we want to keep as much pressure as we can off of that brainstem. And then 2 more things I want to point out to you. You see those little bones right there? I'm gonna just shut the lights off so you guys can see them. Do you guys see those? Right where those 2 yellow arrows are pointing? Those are called intercalary bones. So what those are, that's calcification of the annular fibers of your disc. And what it is, it's an early sign of degenerative disc disease. So what we want to do, unfortunately those are irreversible, but what we can do to help you is we can restore the motion to this area of your spine, because motion provides hydration to the disc to keep them healthy, and we can slow down that degeneration process. Okay? And the last thing I'm going to have you look at, is your discs. So if we're looking at your discs, this one looks pretty good, this one looks pretty good, but as we start to get down here, they start to get narrower and narrower, and right here, we're almost bone on bone back here, right? And it's really, really thin right there. Do you see that?
Yes, I do.
So why you might be having that tingling in your fingers is because the nerve root that exits between, this is C7 and T1, is that C8. So you're feeling that nerve tingling on that distribution route. Okay, so what we need to do here is, again, we need to restore the motion to slow down that degeneration process. And I'm going to show you how it's moving here shortly on your video fluoroscopy, okay? Sound good?
Awesome.
All right. So we took a picture of him side, neutral, lateral, that we just went over. Now I also took a picture of his pelvis, an x-ray of his pelvis. So this is what we're looking for with a normal pelvis. We're looking for symmetry. We're looking for even widths on the ilium, right here. We're looking for these 2 holes, which are called obturators, to be symmetrical. We're looking for this line right here. It's called the sacral center line. We want the sacrum to be directly over the pubic symphysis and just above it. And then we want the lumbar spinous processes to be straight with that line as well. Okay? So that's a normal pelvis. And then this is your pelvis. I don't know how that slide got in there. It must have slipped in. All right. All right.
That'll explain a lot of stuff.
All right. So what we have here, this is your actual pelvis X-ray, right? So we're pretty symmetrical. So from this ilium to this ilium, it looks about the same width, right? These obturators look about the same size. What we do, let me go back 2 slides. What we want to see here is like a heart-shaped pelvic brim, pelvic opening, okay? And so what we see on you is we see a smaller pelvic opening. We also see that the sacral base is being overlapped by the pubic symphysis. So what happened is your pelvis rocks posterior and inferior like that, so that's why we're getting this image. And as we're going to see here when we look at your video fluoroscopy, it's causing a lot of your lumbars to lock up. And we'll talk about that here shortly, okay? All right. So now that you went over the static x-rays with them, the 3rd step of our analysis is video fluoroscopy. So video fluoroscopy, we study the motion of the spine. The way we study the motion of the spine is with the gold standard in spinal motion analysis, which is video fluoroscopy. So what our goal is to find the bone that's not moving and to unlock that vertebra. We want to restore the motion, right? So why is it so important to restore the motion? So in your spine, you have several synovial joints, right? Namely facet joints. Within those facet joints, you have proprioceptors. What proprioceptors do is it sends the information to your brain to tell you where your body is at in space and also how your body's moving. So if you have a lack or an aberrant motion, what you're going to see is you're going to have distorted signals going up to your brain. And if you have distorted signals going up to your brain, what's going to be coming out? Garbage in, garbage out, right? So that's a model of subluxation that we call disafferentation. Because the afferent signals aren't being properly signaled up, and then the efferent signals aren't properly being sent back out. All right, then the last thing I want to talk about before we take a look at Dr. Andrews' video fluoroscopy is the radiation. So one of the biggest misconceptions about our video fluoroscopy is that it exposes our patients to some insurmountable amount of radiation, right? In fact, the radiation that they get exposed to is quite negligible. I think a lot of people have that misconception because in the medical field they use video fluoroscopy for swallowing studies and stuff like that, and the patient has to stand in front of that for long period of time, and they're also at a higher MA so that they can see that soft tissue. So this was a study. These numbers were from a study done by. He was a Pierce practitioner, and he used a dosimeter. The dosimeter is a device that measures the radiation absorbed on the patient, and it measures the units in MRS or millirads. So what we're looking at here is he took a fluoro for 30 seconds, and the radiation that the dosimeter showed was 15 MRS. For an average cervical x-ray, 62 MRS, average pelvic, 466, one CAT scan, 1,000 to 3,000 MRS. So as you can see, you could take 2 minutes of video fluoroscopy, and it's equal to one average cervical x-ray, right? This is 4 times 15 is 60. But you could take, what, 100 30-second video fluoroscopy before you equal one CAT scan? Does anyone have questions on the radiation? Because that's big question that we get asked. Yes, sir.
How much do you get, do you know in millirads, how much you get from being in an airplane?
I'm not sure.
I think a cross-country flight from Florida to California is like 1 or 2 like full spine X-rays or something like that. I think
So maybe like 1,000 or something?
yeah.
And also the safe amount of radiation that they recommend is 5 rads per year. So you can do a ton of those, right? 5,000 millirads or 5 rads. All right. So now what we're going to look at is normal motion. So I'm going to shut the lights off for this because the quality of the video fluoroscopy seems to loses its quality as I converted it to a DVD to digital. So it's a little tough to see, but I think if we turn the lights off, you guys will be able to see it fine. So I'm going to explain this to the patient on how the spine should be moving before we show him how his spine actually moves. Go ahead and play it, Brand.
Down in front.
Sorry, guys. All right. So what we're looking at here is the pelvis. So that's your pelvis and that's your lower back. So what we're looking at when we're looking at your lower back is he's laterally flexing to the left and the right. When he laterally flexes to the left, or sorry, this is the normal motion, right? So when she laterally flexes to the left and to the right, the spinuses should be moving to that same side and we should have that curve. Can you rewind it real quick, Brandon? That's perfect. So see as she's laterally flexing to the left there? All the spinous processes are coming at a curve like this. They're all rotating to that same side, and that's what we're looking for. We're also looking for symmetry of both sides. So they should look the same on both sides, and that looks perfect. This was a girl that I got fluoro that had never been adjusted, by the way, and she has normal motion. All right, and then what we're looking for in the cervical spine, so this is the thoracic and lower cervical spine. We're looking for when they rotate their spinous processes. Can you rewind it? This video is too fast for me. All right, so we see the spinous processes right here, right? So what we're looking for is when they turn their head to the right, they should be turning to the left. When he turns their head to the left, they should be turning to the right. So go ahead. See how they all moved, and we're looking for that same curve, and then we're also looking for symmetry again. This should look the same on both sides. Now what happened? Go ahead and pause it. What happened is they took a step forward, so they stepped out like this. Now they're going to extend their head back. So now we're looking for the spinous processes to come together. Because the extension, your spinous processes all close down on each other. So go ahead and play it. And this is a really good sign here. She took her head all the way back. She had really good extension. So you're not even able to see it here, but we're going to go to the lateral view, and you're able to see it on there. All right, so now we're looking at it from the side profile. Go ahead. So she's going to go into flexion first. She kind of did weird flexion. She didn't know what to do. That's why it's good to give your patients really good instructions before they go into these under the fluoro. Save them radiation too. All right, go ahead and pause right there for me. So what we're looking for whenever the patient goes into flexion is we want a smooth rolling curve here. We want to see all the spinous processes open up, and we want to see these IVFs open up as well. So see how we can see the IVFs right there? And the spinous is all opened up, and if we drew a line back here, it would be a smooth rolling curve. So that's what we want to look for in flexion. Now she's going to go into extension. She's going to bring her head back. And again, that's a pretty textbook perfect extension. There, you draw a line right there. It's a smooth rolling line. Again, all the spinous processes close in on each other. You don't have any open IVS. You want them all to close down on each other. Go ahead and press play. We better go into extension again because we're looking a little bit lower here because it's hard to see through their shoulders. So you have to take the central ray down a little bit so that you can see it a little bit better. All right, let's go ahead and move on to the next slide. That's pretty much all you need to see there. All right, Dr. Andrews, now we're going to look at what your spine looks like in motion. So go ahead and hit play. All right, so we're starting at the pelvis, at the low back again. These are the lumbar spinous processes right here. He's laterally flexing, but you can't even tell because his lumbars aren't moving. But he's laterally flexing to the left and the right. Especially right here. You're not seeing very much movement at all, right? Go ahead and pause it real quick. So Dr. Andrews, did you see how you didn't have very much motion in those lumbar spines?
I did.
So the reason you strain your quadratus lumborum often is because your quadratus lumborum muscle attaches to all 5 lumbar vertebrae. So if your lumbars aren't moving when you're making these movements with your muscle, what it's going to be doing is going to be pulling on that muscle excessively, and it's going to be causing those strains. So our goal is going to be to restore the motion back to the segments, okay?
With that bottle that I swallowed, have anything?
All right, yeah, keep playing. All right, so now we're going up. You can see the heart beating. It's pretty cool, huh? All right, so now we're looking at the lower back and the upper neck area. So again, we're looking for, when he rotates his head here to the right, we're looking for the spinous to move to the left. Sorry, guys. Oh yeah, that's just a button on his shirt, just so you guys don't think it's like something else. All right, and then he's rotating his head. His rotation actually looked pretty good. You have good rotation in your thoracic and cervical area. Now we're looking at extension. So again, we're looking for these spinous processes to close down. Did you see how this one didn't move at all? That one didn't move at all? Go ahead and pause it. So those are the 2 vertebrae that typically we'll see with nowadays, right? Because those are the 2 vertebrae that get locked up when you're constantly texting on your phone, when you constantly have your head down studying. It's the C7, T1, T2 area that's going to get locked up on you. So pretty much every student that we see who gets video fluoroscopy, they're going to have that lock up there. So, but it's not 100%, so you just can't go around smashing them. All right, go ahead. The guy who's taking the video fluoroscopy forgot to pause the recording, so I had to fast forward it. Clinton Orsini, if any of you guys know him.
Just give him a shout.
Shout out. All right, so now we're looking at flexion here. So that is your flexion. Pause it. So look at this. Does that look like a smooth curve, rolling curve like we saw in the previous patient? You can objectively see that, right? You can see that the IVS didn't open up here, right? There's no IVF opening up in any of his segments. Granted, they did move, but they didn't move like they should. Go ahead and keep playing it. Now he's going into extension. Want to see everything lock up. Look right down here. You see how there's still a space between this vertebra and that vertebra? It's really hard to see. We're going to go down a little bit and it'll be a little bit easier to see. But when you're actually taping it in his office, he has it on a digital screen, so it's pretty clear on there. Again, flexion, straight line, nothing there. Sorry, Dr. Andrews. All right, so we're going to go into extension, I think, one more time here, and then it's going to end. So look right here. It's going to come down, but it's not going to come down near as it should. So this is T2, or sorry, this is T1, and that's C7. So do you still see that space right there? Did any of you guys see that?
Yeah.
You can see that, right? Yeah. All right. All right, let's go on to the next. Okay, so.
Hey, Randy, can I say something real quick?
Go ahead, bud.
If you go back to that, you know, we can see Dr. Andrews has a pretty good structure, right? Like he's almost got a pretty good lordotic curve, but the function isn't there. You know, so that's what you get with this video fluoroscopy. We get to see the function, and ultimately we all know the function is, you know, what we really need to go after.
Good stuff, man. All right. So the reason that his neck was locking up like that, but so typically when you see flexion locks, you're gonna see them in like the mid-cervical area. But that's what I was looking for at first. But everything was moving. So what was locked on him was C2. C2 initiates all the flexion of your cervical spine. So if C2 is locked up, the rest of your vertebrae are gonna be locked up. That's why the rest of his spine looked like that, and they weren't moving as they should. But what was causing that C2 to be locked up was that T1. So T1 and C2 are mates. In the Pierce result system, we have vertebrae called mates. You'll learn about them if you keep coming. So they're mates. So T1 controls C2. So what we think and what our philosophy is that you adjust T1 and it's going to unlock C2, which is going to unlock the rest of the spine. However, I mean, once you unlock T1, then you might have something in the mid-cervicals that you can see because it'll be able to function properly once we unlock the C2. I know that was a lot. Did that make sense to you guys? Yeah. All right. So today we're going to adjust T1. The reason we only adjust one segment, and they call me One Bone Randall, is because we want to give time for the body to heal. And also, more importantly, we want to be able to establish a pattern for that one listing so that we can keep track of our listings. Okay? So that's going to be his T1 pattern. So before I adjust you, I know you're excited. I'm going to show you guys the table. So, yeah. So this is the Zenith 60 Pierce table. The reason it's called a Pierce table, well, right? We all know Thompson drops. We have the 4 drops here. So we have the pelvic, we have the lumbar, we have the thoracic, and then we have the cervical. But the reason it's called a Pierce table is because it has a 3D headpiece on it. A headpiece that Dr. Pierce invented. So what this headpiece allows us to do is it allows us to remove all of the biomechanical aspects of a subluxation while maintaining a specific and consistent line of drive. So what I mean by that is this headpiece can laterally flex. That statement is made. And it can also rotate. So it laterally flexes this way. I've never used the lateral flexion component on it.
It's the little starfish on the left.
What's this?
So unlock.
Yeah.
So what the lateral flexion component is used for is head tilt. So if someone has head tilt to the right, we're going to tilt it to the left to get their head on centered, and then we adjust them just straight P to I to S. So we're going to adjust the patients the same time every time. What did I say?
P to I.
I said P to A, you just didn't understand me. It's P to A. You guys are all so excited.
Too much disappointment.
So that's what the lateral flexion component can do.
You're my doctor.
But my favorite part of the headpiece is the rotational component. So what the rotational component does is say you have like Mopal listings, a PR. So if you have a PR and the spinous process is rotated to the right, what you do is you just rotate the headpiece. Can you guys see that? Rotates like that. So it rotates the spinous back to center. So then all you have to do again, P to A, I to S adjustment. So you're doing the same adjustment every time. You're not having to take the rotation out with torque or like climb on side of your patient or anything like that. So it makes it pretty convenient for you and the patient. All right. Moment of truth.
You ready?
Yeah. So what we're going to do, we got to switch over to this computer because this has the scans on it. So.
Hey guys, let's give it up for Randy giving this awesome presentation. That was a ton of information that he just got. By the way, I'm Baxter, for those of you that don't know.
Baxter was another member of the old E-board.
I'll stand up for this one. Yeah, there are a couple of us floating around. This was a lot of information. It was all really good. This is very like seeing is believing. This is the the nuts and bolts of Pierce. If you have any questions, that's totally fine. My favorite phrase to use at this time of year is drinking through a fire hose. So if you didn't catch everything, we will have multiple clubs going over thermography, specifically fluoros, flexion extension views, a little, a lot more detail than what we went over today. So if you have questions, write them down, or feel free to pull anybody in a blue polo and ask them after club. Cool?
Thanks, guys. Thanks, guys. You ready, Randy?
I messed up with the computer, sir.
As many of you guys know, I have a problem with technology, so we're trying to fix it over here. It's the computer died.
I really just left my phone up here.
Camera's about to die, you may get a few more for you. Wait until you get on there.
My batteries are dead.
About, you can probably take a few more. I can take them on
It's up by Hastings office.
You can sit there if you want to.
Come up to the front if you want to see it.
Yeah, if you guys want to get a picture, come up to the front, but try not to block anyone else. And it's kind of difficult in a small room.
Like, you need to see this. I said, like, you need to see this. Look at how people come up.
We need to attach that.
That plugs you back.
I think we need to attach that to here. And I
think it's in the back.
If you see one on the wall, because Andrew's essentially
Too many syllables?
Why don't you just take a picture and then, like, put it in the...
Huh? Whoa, why you gotta do that to me right before I tell
You want me to take a picture of it? Why don't you just take a picture of the scan and then put it on a PowerPoint? Real quick. Like that would be easier.
Just turn the computer around. People would have to see
Which I think a lot of people.
well, it was sitting here.
This won't plug in. Which computer is this?
It's these
Well, we're not going to see his scans?
That's definitely right over there.
How about you?
one I was trying to plug in.
Never mind, false alarm. Well, now you gotta switch the settings on the...
You gotta pull this up.
I think you need to change the settings over here.
Yeah. I'm not tech savvy, so...
Alright.
No, it's working, it's coming. You guys
Go
are
to
cool.
the,
Yeah, you're gonna